In the meantime, I'll ask Dr. Marian Pauly to present her talk on bridging the gap, interdiscipline exposure and training. She's the head of oculoplasty, orbit and ocular oncology in the Giridhar Eye Institute here in Kerala. So, welcome.
I'm AIOC for giving me this opportunity, and I'm looking forward to bridging this diversity. So my task is to bridge the gap between interdisciplinary exposure and training. So we know fellowship in oculoplasty prefers a trained to be safe, independent practitioner in the specialty, and we all know oculoplasty is like it comprises of eyelid, oncology, orbit, aesthetics, and abdomen. But it's not ocular alone anymore. We have got lots of responsibilities, like apart from saving the glow vision, we have a responsibility to save the life, and as well as psychosocial rehabilitation also. So now, what can be done for this? So it needs interdisciplinary exposure and training. How? Why? So this, I hope I will be able to answer these questions. So this is a 64-year-old female, active thyroiditis with compressive neuropathy with fungal corneal ulcer, right eye PL, left eye 2 meters. See the amount of specialists who has handled this patient: oculoplasty and blepharotomy, endocrinology, systemic control, ENT surgeon, orbital and optic canal decompression, rheumatologist for immunosuppression, radiation oncologist for EVRP because of the recurrence of the disease. She developed steroid-induced psychosis managed by psychiatrist, and finally she underwent cataract surgery with an IOL surgeon, and final outcome was vision 6, 6 and 6. Now, this is not always. On the other side of the coin, this is the same disease, more or less, right eye, again active thyroid disease, 64-year-old driver, right eye no PL, left eye PL plus present. He was denied decompression because of the high risk anesthesia. Even though he underwent radiation, vision has improved to 2 meters, but unfortunately he committed suicide. So there comes the role of psychosocial rehabilitation also by the oculoplastic surgeon. So in the diagnosis of various systemic diseases, we need to work together. This is a patient presented with the adenitis. She presented to the ENT surgeon for deafness. Germanic membrane biopsy was non-specific. We did a lateral gland biopsy, turned out to be GPA. So to diagnose the systemic disease, we know orbit is a Pandora's box. We need a close association with other specialists also. Again, managing complex traumas, we always work together: neurosurgeon, maxillofacial surgeon, and oculoplastic surgeon with the patient-specific implants, socket reconstruction, and prosthesis. Coming to the neoplasms, I need not mention orbital, adnexal, intraocular. It is teamwork, medical oncology, radiation oncology, head and neck surgical oncology. All these tumors are being managed by multiple specialists. So now coming to the plastic surgery. This is a 72-year-old male, entropion following blepharoplasty by a plastic surgeon. Usually we get entropion. Why entropion? So he had an ocular cicatrization pemphigoid which was missed, and after surgery he developed lid got inverted and we corrected the entropion. So I would like to present this quote. This is a quote sent to the European group of plastic surgeons and dermatologists. Who does it is not so important. What really matters is that it is done well. And to do it well, we must take into account that oculoplasty may be primarily aesthetic surgery, but the function of the eye must be mandatory, protected, and preserved. So the functional aspect, oculoplasty is not only aesthetics alone, it has all the surgeries and all the procedures has got a functional element too. Now coming to the dermatology, we know we work in close association with dermatologists, especially in the field of aesthetics. More than that, there are some other diseases dermatological diseases which can affect the eye, which needs intervention from our oculoplastic surgeon. So this is a case of ectropion. He had pemphigus on immunosuppressant, chronic ectropion, and we did ectropion correction and we did well. And later we underwent cataract surgery also. Now, coming to the radiology and pathology, this I need not mention. It is like hand in hand, you and me today, tomorrow, forever. So these two specialties are like the right and the left hand of us. So including interventional radiology. So from all these things, we know how important interdisciplinary approach in each case. So interdisciplinary approach helps in the exchange of knowledge and it helps us to manage complex cases in a very effective manner. More than that, it reduces inadvertent medical errors and legal battle. That improves patient care and outcome. More than that, it builds a leadership, teamwork, and communication skills. So team means together everyone achieves more. So that is really, really very, very important in the field of oculoplastics. So this is another case, 45 years, again active thyroid eye disease, but he has chronic diabetes with renal failure, awaiting transplant, decompression was denied, seen by multiple. Here comes the class 2 matching. We just did a blephariectomy under local anesthesia and he did well. So what can we do? What can be done to develop such kind of approach in our fellows? So I am suggesting, like, it is for a discussion also. One is interdisciplinary meetings. This slide I have taken from BOSS. So they have invited head and neck surgeon, skull base surgeon, then all the other radiologists for the oculoplasty meeting. This is I have taken from this BOSS website. Another thing, surgical skills transfer course. So now we know Akshay and working, Kasmiri Madam and I master. So lots of things we can learn from other specialities by this short courses, 2 days or 3 days course. So that has to be done. Another thing that can be done is interdisciplinary clinics. So we can work with the rheumatologist, or if they are willing, they can come to our clinic at least 1 hour in a week or 2 hours in a week or 2 hours in a month. So interdisciplinary clinics that will help to improve the knowledge as well as patient outcome. This one I have taken from internet, the rheumatologist and oculoplastic surgeons community partnership in Oregon. There is one Indian oculoplastic surgeon also, Dr. But another thing that can be done is to attend other specialty meetings. For example, after 2 weeks, in a nearby we are having Indian Thyroid Society meeting of their annual conference. Similarly, you can attend all radiation oncology conferences, aesthetic surgery conferences. So that also will improve our knowledge as well as our fellows' knowledge. I'm so blessed in the Eye Institute. We work with a group of specialists from all these specialties and we have developed a good teamwork. So to conclude, cooperation rather than competition is the key to success. And oculoplasty serves as it bridges the gap between the multiple specialties. So I think we have to work together to develop this interdisciplinary approach towards each oculoplastic piece. Thank you.
Thank you very much, Dr. Marian. So that was an excellent coverage of all that is important for us to remember that we are just not dealing with the eye; it's part of the body, and there are multiple other things that we need to be trained and keep our eyes open for when we are dealing with patients. So I think we have a little bit of time, and we have experts like Dr. Akshay and Dr. Kasturi who have been long involved in training residents and of course setting pace for a good oculoplasty oncology program. So we'll just take a few comments and any questions that we have. So maybe you can sit and we can have your next.
Very good presentation. I always believe that oculoplasty is something a combination of science and art, and I also do some amount of intersegment surgery. I feel this is the only surgery which is non-reproducible. Every surgery is different, every patient is different, and when we look to the oculoplasty surgery, though we basically do around the eye, but actually we need to have a full knowledge about the face, about different muscles, because all the muscle ultimately ends in the eyes, periocular region. And if you really look to the literature, the face doesn't belong to anyone. It belongs to the oculoplasty surgeon, it belongs to the neurosurgeon, to the maxillofacial surgeon, to ENT, everyone. So what Dr. Marian has mentioned, that interdiscipline exposure is really very important. And even now, I meet my fellows that some are during the training, they need to go and visit a plastic surgeon. They need to go to the maxillofacial surgeon. That is so important because it is a case of fracture that is being dealt by the maxillofacial surgeon, that is also being dealt by a oculoplasty surgeon. But the approaches are different. So you should know every approach, whether you need to go through the skin or through the inside the mouth or through the orbital approach. Likewise, I feel that every aesthetic surgery has a functional indication and every functional surgery has an aesthetic requirement. So this interdisciplinary exposure training during the residency and also during your fellowship program is very, very important, because we are here to learn from each other. Because this is a part which is done by everyone by different approaches.
I think Dr. Marian's presentation was fantastic, and it just gives you an idea if they say that spectrum of cases was seen in a 2-year period. The fellow who's been accompanying her would have such exposure to the kind of cases, the different specialties that handle it, and then that is the self-propagating prophecy, because now there is a fellow who's trained, who is aware of how different specialties work, and that person may eventually will have been trainers of his own, and also in his clinic he will be the first one to be able to identify who needs to go to a radiologist and who doesn't need to. So I think not having exposure to interdisciplinary patient care during training eventually trickles down to your practice, because then the moment you see a patient of thyroid eye disease, that saying, if you have a hammer in your hand, everything you see looks like a nail. So if you've never dealt with interdisciplinary management of a patient, you will keep trying only your technique of medication. Like thyroid eye disease, the only thing you can give is steroid, because as someone who doesn't have exposure to multi-speciality care, that's all they do. So I think it's a wonderful idea that.
So Akshay, so this is a problem that we face in medical field in India. A fellow with Dr. Marian, with the story of you, would obviously see this wide, spectrum of cases, get an experience of understanding how to deal and when to look for support and what are our limits. And, even in the best of cases, we are all looking for support from interdisciplinary experts. But we know a lot of places, these fellowships are running where the kind of exposure and the kind of skill that exists is borderline. So what would be your essential, kind of, I would say, rules or guidelines when we are talking about fellowships in oculoplasty, tumors, oncology, as to these? So this is the duration of the fellowship, of which this much time must be spent either directly or in collaboration with something. So that would be something we all should, kind of create and put as best rules.
Looking back, the DN Implement of the National Board curriculum very nicely outlines things. Diagnostic skills, clinical skills, and surgical skills into 3 columns: must have, should have, and good to have. So I think if you are able to do this, recreate a similar pattern in our own departments, where it is must have that they should go say process, illustration, exentation, blah blah blah. Good to have is to have exposure to a radiation oncologist, or at least planning of how radiation is done, etc. So that at the end of, say, when you have periodical assessments, at 6 months, you can assess and see how much of the good to have they achieved, and then they can focus a little bit more on that. And I think acceptance and acknowledgement is the first step. That those 4 domains of knowledge. You know what you know, you know what you don't know, and you don't know what you don't know. So I think it's important to know what you don't know, so that you can assign that for someone else to teach the training, and that comes in.
Answering to Dr. Rohit's question, that how long the fellowship program should be in oculoplasty. That was your main question, right?
Yeah.
So I have really researched into it. So when we first started oculoplasty fellowship, because we were back 10 years back, we had a 2 years program. Then visiting many national and international programs, they said that why you're wasting the time of a well-trained ophthalmologist and making it such a long program. Then we slashed it to 18 months. And then again we slashed it to 1 year. We don't know. It should be like 1 year is sufficient. They're so well-trained residents, so 1 year they should be able to complete their training. But ultimately doing multiple permutation combination in the last 8 years, I have realized that 2 years fellowship is most important for plasty, because what at the initiation I mentioned, it is a non-reproducible surgery, and sometimes one case like the cruisons, I think very recently I presented cruison. you'll get hardly one in a year. And sometimes I am also associated with some charity work, Mission Smile. So those type of cases defect, you will get hardly 2 or 3 in a year. So it should be the 18 months full fellowship program, and the last 6 months they should be given independent OR and a OPD, and at least one OR and one OPD, and 4 days they can be with their mentor. So this really builds up a confidence. And what I have seen in the last 2 years, after we have adopted this, all the fellows that are being trained out from our center, they're very confident in whatever surgery they are doing. So at least they get a 6 months period where they can independently do the surgery, whether it's a fracture, it's a thyroid operation. Like normal leg surgery, anyone can do, but those complicated, like those bad cases of thyroid and the discs and the maxilla surgery, all those things. So to make it a very holistic program and a full trained program, I think it should be a minimum of 2 years.
Great. Dr. Mukesh, any comments on training fellows in oculoplasty?
Yeah, actually I joined just now, but I fully agree with Dr. Kasturi that at least 2-year fellowship is required for full grooming up of a fellow in any specialty for that matter. Because he or she needs to read also about that specialty in detail, then follow the mentor, see the patients, do things himself. So it requires 2 years. So that's my take on this.
And about
2 years allows you enough time to see your own followers.
yeah. So and what about how to arrange for exposure in with say a general plastic surgeon, a facial-maxillary surgeon, which are of course exposures that are I think very very necessary when they are dealing with. So how would you consider arranging? Like I said, in a big institution, yes, it's not so difficult, but in like a Mukesh is outstanding plastic surgeon, but now in practicing in a single eye center. So how would you get your fellows to get that widened exposure?
That's one area of real concern actually. So all fellows, they need some amount of anterior segment expertise also, at least in North. Like they want with their oculoplasty fellowship, or for that matter any other fellowship, they want to do some cataract also. They do not want to be away from cataract for 2 years, one. And then the other specialty trainings. For other specialty trainings, we can do licensing with the like-minded person who are having their own setup. Obviously, a fellow needs to go there. They cannot come and teach fellow anything at our center. So one day in a week, a fellow can go there. But this mentor has to arrange with the like-minded person. And similarly, for cataract surgery, also some collaboration is mandated. So that's the real problem for any private center doing surgeries and trying to have a fellowship program.
Yeah, actually, the challenge is this: a lot of specialty is now residing, or expertise is residing in experts who are having their own clinics or own places. I mean, no more they are the kind of place where you're looking at a very large multi-specialty hospital where extensive exposure is being provided. So that is why the challenge in our kind of specialties, where we want them to have exposure to other experts, but obviously that's not a routine part of the curriculum. So any other comments before last couple of minutes before we close this? Akshay, any tips on how to run a good teaching program? Yes, please.
So what are they doing for the 3 years of MS?
So that's a question I think a lot of us are
I'd like to
kind
add
of
one
trying
more
to
thing.
search out.
There's a, what I have concluded over these few months, I should say, there's a thought process going on in the resident's mind. Residency is for earning, fellowship is for learning.
So I think it's, like I said, very unfortunate. We're also kind of really realizing how our residents should be, and that's what I was mentioning, that unfortunately many of these educational institutions lack the expertise and the exposure to multi-speciality, which should be actually, why should we need so many fellowships and training programs? I mean, in our time, a resident was trained to even go do retinal surgeries in their, medium-sized towns, and many of my batchmates never stayed back in RPC to continue doing any senior residency or any further training. And today they are like leading experts in plasty and retina in their own particular places because they just continue to do that. So, and had good exposure to specialty as a resident. So it's unfortunate that it's getting down and our residency programs are deteriorating, and therefore we're talking more and more of, you know, getting our fellows to learn specialty as well as continue to train them and upgrade them in general cataract surgery.
Sir,
I feel that no.
faculty where we have the MS and
Absolutely, I think it is. I mean, you can, as Dr. Kim had mentioned, you reap what you sow. So if I don't teach them well, how can I expect them, or if I don't perform my specialty or, you know, transfer my knowledge to them, how will they know? So it is bent upon us. I think it is sheerly our responsibility to train our next generation. It is absolute. If I don't train the next, how do I expect my fellow to look after my OPD for me? So it's, I mean, other than of course a moral responsibility, it is an actual benefit for me. Like I'm here today, and my OPD is tomorrow. Somebody has to see that. If my senior resident or fellow is not adequately trained, who is going to look after that? I'm going to get phones on my cell all the time. Nowadays, there are not those days when you just, you know, forget it and they keep calling and trying and searching in the hospital. Now everybody has cell phone numbers. So,
I feel the residency is basically we really need to treat them in comprehensive ophthalmology so that they come out as a safe surgeon, they come out as a safe doctor. That is very important. And fellowship is something like super specialty, like a PhD program. We don't have PhD. Like you cannot expect a residency because we have unit posting 1, 2, 3, 4. In the 3 months unit posting to learn how to do a back forwarded fracture, how to do a decompression. But yes, there must be a safe surgeon. And today in the morning we were discussing that in the court of law, if there's any complication coming, if it is whatever is in the curriculum, they should know. Like supposing someone had given a arrestin injection and came out with some complication, and there's a case been going on, and he says, no, I have done a fellowship. No, that will not, give any, credit in the court of law. What they say, that isn't in your residency program, have you learned it? Okay, you are a MS, you're supposed to know you have done the right thing. But we are talking about fellowship program, that is something super specialty. So for that, it is not possible for the residents within 3 years to know everything. But what I believe, we need to train the residents in such a way that they are very good comprehensive doctors and they can do good cataract surgery. They should be able to do the basic oculoplastic endopion, ectopiontosis. They should be able to do a good pterygium surgery, the lasers, everything. But sir, those complicated cases, I don't think residents will be able to pick up. And 6 months to go in the thesis.
They should learn to treat the vast majority of 80% patients and recognize those 20% patients which they can't handle and need to be referred to the appropriate person. So that's, I think, the crux of any residency training.
Can I add one more
Yeah,
point?
please. I think we do that.
Looking back, these wrong seats are sown during MBBS. The day they join MBBS, they are seeing just like dots, PG. That's the biggest problem that we are doing in medical college. It's having MBBS students as well as PG, and if they are not interested in other specialties, build the MBBS.
When the bigger problem is pre-PG or need. Because of that, now MBBS practical training is zero. Zero. So saying this,
MBBS is an unemployable graduate. Right?
No, forget about employment, but their actual practical training. Previously, resident used to do independent suturing, hernia repair, hydroceal repair. They were practically useful. Nowadays, it is things out of the field.
It's unfortunate that it's come to that, but yes, we should do our bit in whatever we can, both from a residency perspective and of course from fellowship. So I think we'll close the session here. Thank you very much. Okay, sure.
I was there as an examiner in a medical college. I was checking the copies. I started having tremors because these people are going to handle me. Unfortunately, I don't want that. If I get admitted, what will they do?
It is incumbent upon upon us to raise the level of teaching and training for the next generation, so that and that's what these discussions were for. Hopefully, we'll be able to take back and implement some. And again, thank you very much. Thank you everybody for